Anyway, we'll be talking about acute facial palsy. And yeah, like Dr. Carr mentioned, I went to med school here, so I've been here quite a bit. And let's see, there it goes. So we will be talking about the workup and diagnostic considerations for facial palsy. We'll go over the clinical practice guidelines that our academy put out. Briefly, we'll talk about treatment of Bell's palsy and kind of permanent flaccid facial palsy. Kind of facial reanimation stuff. And then ulterior motives, we'll see some pictures of UB Buffalo. So first photo is of the Buffalo Niagara Medical Campus. And I started here and this thing did not exist. And now it's this huge mecca of buildings. So here is this new med school that I never got a chance to visit because it got built after I finished. This is our new children's hospital that we moved to, and Linnea experienced the horrid transition from one hospital to the other. So during our second year, and it's beautiful on the inside, and we have an OR. You could probably do 2 tonsils in each OR at a time. Like, that's how much room we have. Buffalo General is next door where we get our otology experience, and then we have Roswell Park Cancer Center with a great head and neck experience, as well as some facial reconstruction and Mohs and some of that stuff. So first we'll talk about anatomy. Linnea just went over this. Lots of segments of the facial nerve. There is an intratemporal portion as well as an extratemporal portion. So you have this labyrinthine segment, which is the narrowest part of the facial nerve course. It makes one turn. It gives off the greater superficial petrosal. Like Linnea mentioned, it hangs out near the cochlear process and then makes a second turn to go into the mastoid, and then it comes out through the stylomastoid foramen. And then, like she mentioned, there's a bunch of mnemonics that you can use to remember the extratemporal portion of the facial nerve. Here we use 10 zebras bit my chicken. So you've got the temporal branch, the zygomatic branch, 10 zebras bit buccal, the marginal mandibular, and then the cervical branches. The middle portions tend to arborize a lot more, so even if some of these are injured either iatrogenically or just kind of happen to be injured by accident, you don't get many deficits per se versus the other ones which don't arborize as much. So today we'll be talking about facial palsy. Not a great look for if you're trying to be involved in society. There are functional deficits. This patient probably has issues with blinking. He might have drooling. He might have nasal valve collapse and have difficulty breathing through his nose. There's a psychological aspect that you look different from those that are around you, as well as the social issues that come with facial palsy. So if this person comes and walks into your clinic, the first thing you want to do is get a history. So was this facial palsy, was the onset immediate or was it delayed? Did this kind of come on suddenly? Was it a complete facial palsy where you're not able to move your face at all, or do you get some kind of motion here and there? And you want to think about contributing factors when you're thinking about your differential. So was your patient sick recently? Was there recent injury? Did they have surgery recently? Here in the summertime, we think about Lyme disease. So have they been outside? Any tick bites that they've noticed? Do they have any medical comorbidities? Of course, you're going to ask their past medical history, their past surgical history. And have they had facial palsy before? And then you kind of elucidate some of these review of systems. Just like Linnea said, she came up with some examples, but again, history is very important. And then the other component that's very important is a physical exam. So you want to do a complete head and neck exam. Of course, we're going to be focusing on the otologic exam as well as your neurologic exam, including the cranial nerves. I'll say that if you have a facial palsy and then you notice a bunch of other cranial nerve deficits, you probably think something's going on intracranially, or some cancers like spreading terribly. When you're doing a facial nerve exam, you want to kind of look at their musculature at rest, and then with certain movements, so you'll have them raise their eyebrows, have them blink softly and forcefully. You can have them puff out their cheeks like a blowfish, have them show your teeth, have them smile, have them show your lower teeth, and then you could have them tensor platysma. And here's just a picture of someone with a facial palsy going through some of the different motions that they've got. One of the things that we use to kind of grade facial palsy is called the House-Brackmann facial nerve grading system. And it's a grading scale from 1 to 6. 1 is really easy because it's normal. 6 is really easy because there's no movement whatsoever. It's the stuff in between that gets people confused. And I think as a med student, this is probably the one that you're gonna kind of be asked about if you're doing a sub-I or an away, if you're allowed to do an away. So 1 is easy, 6 is easy. So how do you differentiate 2 through 5? Well, for me, I use 3 and 4 as a differentiating factor. 3, you can, oh, I made the wrong blue thing. 3, you have complete eye closure, versus 4, you have incomplete closure. So that's kind of how I tell 3 and 4 apart. And then between 1 and 3, there's like very minimal difference. You have to like look really up close to see if there is a difference from one side or the other. And then for 5, there's asymmetry at rest. So I would probably, as a medical student, commit this system to memory when you're kind of thinking about it. However, as we'll talk about on the next slide, there are some downsides to using this because you could injure specific branches and it doesn't really apply to the global picture. So some other things that people use for outcomes tracking, they'll use the Sunnybrook facial grading scale. It's a way more involved. It's down here in this corner. It's based on 3 visual analog scales. So the patient at rest, dynamic movement, as well as if the patient has synkinesis. And we'll go over definitions in a little bit, but the scores go from 0 to 100, kind of makes it a little easy, and you kind of grade each area separately. So it's kind of more granular as opposed to the House-Brackmann scale. There is the eFace, where it's also a visual analog scale right here, and again, graded separately. And then finally, I won't go over the MEI facegram, but then there's the Emotrix, which is, I think, really cool. Like you can put this photo up into the computer and it puts all the dots where it needs to go. It's automated and it standardizes it for each photograph, and you can get all the different measurements that you need from this software. And it's available for free actually from the Sir Charles Bell Society. I haven't personally gone to the website quite yet, but if you're interested in this stuff, you should probably check their website out. They've got this available for free as well as the MEI facegram. The nice thing about this is that you could actually compare lots of photos, and I think they're working on trying to compare videos at this point, but something to think about when someone asks, oh, what else can we use other than the House-Brackmann scale? And you can list all of these. So here's another picture of buffalo. Oops, maybe not. There it is. So this is Canal Side. There was this giant duck that came down to visit at one point. But if you go to this, kind of if you turned your body, you'd be facing our hockey rink, which I'm blanking on the name right now, but the Sabres play there. Dr. Nagy's gonna be so upset. But the Canal Side, pre-COVID, people would go down here and they would do yoga. There's free movie screenings that usually happen during summer. It's lively. There's a bunch of, sorry, what? KeyBank, is that right? Yeah, KeyBank. I was blanking.
The HSBC, and they called it, what do they refer to it as during the playoffs?
First Niagara.
Hot sauce. No, that's not right. Hot sauce. I don't know. I'll think of it.
Anyway, the KeyBank Center is down here. Usually some attending won't be able to show up, and they ask the residents if they can, if anyone's available, and we'll go to some hockey games every once in a while. We'll see what happens this year. Yeah, so that's this one. So again, you have your history, you have your physical, kind of leads you to what your path or what you think might be going on. And there's this huge differential diagnosis. You want to be able to do things systematically. So people use the Kitten's mnemonic. This is out of Pasha. So K is the congenital, I is the idiopathic or infectious, toxins, trauma, tumor, endocrine, neurologic, and then the systemic stuff. I will say from this list, the most common is Bell's palsy, which is kind of why we're going to be talking about it. But that is idiopathic and a diagnosis of exclusion. So you have to really rule out everything else before you label someone with Bell's palsy. So just to keep going, so facial palsy, this gives you an idea of how to kind of work up someone with specifically facial palsy. If it's partial and it's not progressive, then hopefully you're thinking maybe it's Bell's palsy and you can give them steroids and acyclovir and it resolves. If it's progressive, then you want to consider imaging because maybe you're thinking something a little bit more insidious, whether it's tumor or some sort of autoimmune condition, and you want to kind of elucidate some of the symptoms, and maybe you'll find a cancer or something, and either in the parotid or intratemporal. So that's partial. And then if you have a complete facial palsy, you want to do your good otologic exam, and you're going to see if there's vesicles or no vesicles. If there's vesicles, then you're thinking Ramsay Hunt, which I won't really go into, but it's a herpes infection. Really painful. You get the complete facial palsy as well as the ear pain that develops with the vesicles and rupturing. If there are no vesicles and you've ruled out everything else, then presumably it might be a Bell's palsy, and you start the Bell's palsy treatment, which we'll go over again in just a little bit. The things that start getting dicey is if your Bell's palsy or your facial paralysis does not start to improve with your treatment, which then you can start going into these ancillary tests such as the ENOG, and like Linnea mentioned, we'll talk about decompression and stuff, but you can try doing steroids again, depending on your findings. And then again, if it's still not resolving, maybe something else is going on and you want to work that up. And then post-traumatic, let's say you've got, actually we got this consult today, this guy was riding his bike, he was wearing a helmet, he was probably going a little less than 20 miles an hour, but he got scanned at the ER and they found a temporal bone fracture. Luckily, in his case, no facial palsy, no facial paralysis. But if you did find facial paralysis, depending on the length of time, you could either work it up and go and decompress the little bone chips that are probably impinging on the nerve intratemporally, or kind of wait it out, get some testing, kind of determine whether they're going to heal or recover function on their own or with treatment. So this is more pictures of the residents. This is from last January. We do a little ski day down in Ellicottville. It's about an hour south of here. I don't ski. Linnea doesn't ski, but some of our other residents ski. So nice little weekend getaway. One of our attendings has a house down there that he graciously hosts us at. So some other fun things to do if you like the winter sports, in addition to the summer canal side fun that we have. So like I said, Bell's palsy, idiopathic in nature. You have to say it's an acute onset, less than 72 hours. It's not an intratemporal lesion or not intratemporal pathology, although some people question it because of the decompression. And it most commonly happens in the younger age, 15 to 45 years. No specific gendered distribution. And there's some medical comorbidities that it tends to happen more in, diabetes. If you've had a recent cold, pregnancy, you know, the usual stuff. So the Academy put out clinical practice guidelines for Bell's palsy because presumably people in the community have been diagnosing Bell's palsy without really determining that it truly is Bell's palsy, and it's kind of leading to poor care in the community. So what they say is that you guys should be doing an H&P like we've been harping on all evening. And they actually do recommend against doing any lab testing and imaging because that's not going to do anything. You're not going to find anything really. Again, you're only really doing lab imaging or laboratory testing or imaging if it's a progressive facial palsy, not this acute type that you diagnose someone with a Bell's palsy. They have a very strong recommendation for oral steroids. And we'll go over dosing, I think, in just a little bit. But you have to do steroids. The antiviral is an option. You can't give it by itself. So, so definitely steroids plus or minus the antiviral for when you diagnose the Bell's palsy. You want to make sure that they protect their eye, and then the electrodiagnostic testing we'll go over. If they have incomplete paralysis, don't bother doing testing. If they have complete paralysis, it's an option. Again, like I'll bring that chart back up, but it kind of plays a role later in the patient's care after they're diagnosed with a complete facial paralysis. So let's see. Eye care and facial palsy, you can get a lot of issues. That includes lack of ophthalmos, so not being able to close your eye completely. Like in this case right here, this is a lack of ophthalmos. And then actually, while I'm here, this guy is demonstrating something called the Bell's phenomenon, which is an upward rotation of their eye when they try to close their eye, which is a protective mechanism. So this is good. If they don't have a Bell's phenomenon, then they'll still be looking straight out at you, and there's higher risk of injury to your cornea. The other issues that you could have is lower eyelid ectropion, which is this drooping of the lower eyelid, as well as inhibition of the lacrimal system. The lacrimal gland is innervated by cranial nerve 7, so that can be disrupted in situations of facial palsy. And then all of this combined leads to issues with damage to your cornea and the eyeball. So you want to make sure that these patients are protecting their eye because they can go blind from having poor protection of here. So usually for us, we recommend artificial tears every 2 hours while they're awake, and then at night they'll get a kind of thicker lacrimal lubricant. You can do a moisture chamber. Those eye patches are actually kind of dangerous because they're kind of sitting right on the eye, and again, if they can't close their eye, that iPad or eye patch is just going to be scratching their eyeball. So more of a moisture chamber is probably better than actually eye patching or the eye patch, and then you could take the eye like we do in the operating room. So strong recommendation from the Academy to institute eye care in someone with Bell's palsy. So for patients with Bell's palsy, if they have a complete paralysis, it's about 70% of those patients. 70% of them will recover fully from the facial paralysis. So they'll go from a House-Brackmann 6 to a House-Brackmann 1 in 70% of the cases. However, in those other 30%, these patients will recover either to somewhere between a House-Brackmann 2 through 5, or even not even recover from their facial palsy. So the point of steroids is to decrease the incomplete recovery. So instead of having 30 patients kind of having minimal or to moderate recovery, you're decreasing that to 20%. And the patients are usually on something like prednisone, 60 milligrams times 5 days, followed by a 5-day taper, plus or minus usually valcyclovir. You can do 1 gram twice a day for 7 days. And there's some studies, it's a really good study actually, I think. I don't have it cited here. There's a New England Journal paper, I think, that shows that it's decreased synkinesis events also in instituting steroids as well. So let's say you have a complete facial palsy, you've given them this steroid course, you've given them valcyclovir, they're still not recovering, and they're looking to have other treatments. So then that's when you start getting into your ancillary tests, and I'll just go over two. One is the electromyography. That's looking for if there's functional motor units still, and then the electroneuronography or ENOG, which is an electrically evoked EMG. So you're putting these little patches, this pictures from Bailey's. You're putting patches near the stylomastoid foramen as well as the distal musculature. And in an EMG, you're actually having them kind of evoke facial expressions to see if they're triggering any signal, versus an ENOG where you're actually electrically stimulating this area right here to see if there's any facial motion. So in an ENOG, you compare the two sides, and if you have greater than 90% degeneration on the paralyzed side, that's a poor prognostic indicator that you are not going to recover from your facial palsy. After you do your ENOG, you'll do an EMG just to make sure that there are functional motor units before you proceed with the surgery that is controversial. So again, just to hammer it home, you diagnose someone with complete facial palsy. Let's say they didn't have vesicles, presumably a Bell's palsy. Treat them with steroids, they didn't get better. That's when you're doing your ENOG. If they have greater than 90, it should be 90% degeneration, you'll do an EMG, make sure that there's functional units, and then that's when you consider this decompression. So the Academy guidelines do say something about surgical compression, which is they have no recommendation whatsoever. And that's because it's controversial. You have to do all of this testing within 14 days because that's what the study parameters were. So you have to find someone, diagnose them with a complete Bell's palsy, treat them with your 5-day prednisone course and then your taper, and then be like, all right, you're still not recovering. Let's do this ENOG, then the EMG. So pretty small window where you could actually maybe get an improvement. And what they said in this study was that if you decompress the facial nerve, which is actually through a middle cranial fossa craniotomy, they got 90% of these people back to a House-Brackmann 1 and 2 versus the people who did not get a facial nerve decompression. And they ended up getting a House-Brackmann level 3 or 4. No one recovered to a House-Brackmann 1. And this was a prospective multi-institutional study with 30 patients over 15 years. So it's kind of hard to recommend having a craniotomy if people are okay with maybe having a little facial asymmetry. So at least currently the evidence isn't great. And I don't think this has been reproduced quite yet, but it's not kind of a paper that you will want to look at whenever you are a resident, because someone's going to ask you or you're going to read about it. And then just to finish out the guidelines, they looked at acupuncture, they looked at physical therapy, and they made no recommendation, probably because the evidence is kind of wishy-washy. And then if you find a patient and they still have issues, you should be following these patients. And if you are kind of out of your league, then refer them to a facial nerve specialist. So that's time for another break. I should be wrapping up quite soon. So this is Dr. Nagy's house. We do journal club. He is an avid collector of pinball machines. So this is just one side of the wall. And I think he is 26, last I counted. So we had a nice discussion on pediatric otolaryngology topics and then had a nice post-journal club session in the second floor of his garage. So let's see.
It is the reason to come to Buffalo. And Michelle Carroll will tell you that's the only reason she came to Buffalo is at some point to see the pinball machines.
So beyond acute facial palsy, let's say you have a patient who does not get better. They are looking for some sort of intervention. They did not want to do that craniotomy. So ultimately, the goals are to hopefully restore that symmetry, but also to restore function. Like I mentioned earlier, maybe they can't close their eye, maybe they can't breathe through their nose, maybe they're drooling because they can't lift their lip. So in some situations, we're able to do this surgically, and you can get results that look like this. This is from LA, Babak Azizadeh. This is specifically synkinesis, which is not what we're talking about today, but he selectively, or he does a facelift incision, cuts some of the synkinetic nerves that are traveling in the wrong directions, and gets results like this. I'd say that this is new, and evidence is probably still pending to see whether this is long lasting, but something worthwhile to think about. And then this is from another article, but there are lots of things that you can do for both flaccid facial palsy, which is what we'll be talking about kind of briefly, and then non-flaccid facial palsy or synkinesis. So your timeline on these different treatment options depends on whether your facial nerve is intact or not intact. Let's say they have a facial palsy because of a parotid tumor and they have to sacrifice the facial nerve. In that situation, you've got a facial nerve discontinuity, but you've got viable musculature, at least in the first 18 months. That means that you could try to hook up the nerves again, either through a cross-face nerve graft or hooking up the kind of borrowing from cranial nerve 5 or 12. And then, or if the facial nerve is intact, let's say they kind of stretch it out during surgery, during acoustic neuroma repair or excision, there is a chance that it might still recover, but if it doesn't, then there are interventions that we could do. So lots of things that we could do for facial palsy. There are static procedures, there are dynamic procedures. You could do a brow lift, and there are lots of different ways to do a brow lift. This middle picture depicts a direct brow lift, where you're excising skin immediately above the eyebrow and pulling the eyebrow up. You've got lid loading suspension, so if you've got lag ophthalmos, you can make an incision in the upper eyelid, put down a gold weight, and it'll provide enough weight to hopefully that they can close their eye completely and not need to keep putting lubricant in their eye every 2 hours. And then for the drooling, you've got static slings where you can suture the corner of the mouth up to the side of the head. And then the dynamic procedures, hopefully you can get movement either spontaneously or with physical therapy. And there's a different there's a range of procedures you could do. Regional transfers, including temporalis, or free muscle transfer, mostly the gracilis in this case. So just some pictures of some nerve grafts because they're kind of cool. You can do a cross-face nerve graft. This is usually done in kids because adult nerves are kind of slow and your muscles kind of die off if you don't, or the motor end plates kind of die off and atrophy with too much time. But you can hook up from the normal side and go to the other and hook up to the paralyzed side and try to get spontaneity that way. I have not seen the superior one ever in any book, but apparently they decided to portray it. And then, like I mentioned, you can borrow nerves. So on the left side, they're borrowing from the nerve to masseter, which is innervated by cranial nerve 5, and they're sending it to one of the buccal branches. So what happens is if the patient bites down for the nerve to masseter, which is a muscle mastication, they can actually have a bite-driven smile. So when they bite, they'll activate these nerve fibers and have a smile. And then the other one is taking the entire facial nerve and hooking up to the hypoglossal, which just provides global tone to the face and kind of keeps that symmetry so that the muscles don't atrophy. And then people are working on this now, but you can do both, where you provide the nerve transfer from the hypoglossal and provide that global tone, and then the bite-driven smile from nerve to masseter. And then just a picture of some other regional flaps. You can do a temporalis tendon transfer. This is, again, a dynamic thing, but you can, again, bite-driven smile where you bite and the temporalis contracts and you have that smile, that pull right here. Or hopefully in some cases you can do a gracilis, which is free muscle, and you hook up either to the nerve to masseter again or a cross face, and in a cross face you get spontaneity, but you can kind of get that tightening. And these two are usually done in patients who have no viable motor end plates. So in some cases you can combine it and you can get things like this, which I think are satisfying. I think one of the most satisfying cases I've done is a kid who had a brain tumor, and he came for a temporalis tendon transfer, and he's like, I haven't smiled in years, and I was like, this is great. So a few more pictures of Buffalo. This is Lake Effect ice cream. For anyone who's in Buffalo, Lene and I are going to Lake Effect after this talk because they have a new flavor. On the right is a sundae, which was delicious. It's this coconut ice cream with vanilla honey and then this black sesame ice cream covered in whipped cream and this delicious cookie. So if you come to Buffalo, even though it's snowing, Linnea will go eat ice cream. So yeah, in conclusions, Bell palsy is the most common cause of facial palsy, but it's diagnosed as exclusion. Do your H&P. It's important for everything, not just facial palsy. Steroids is the mainstay of treatment, plus or minus the antivirals. And you can really help people who have facial palsy, even though they're outside this window, with some of the facial reanimation techniques. So that's it.
Thank you, Adrian. Does anyone have questions for him?
I have a question. So when it comes to ENOG, do you typically do that as the ENT in office, or do you usually transfer those or refer those patients somewhere else to perform it?
Here, I'll say that we don't do it. I would probably refer it to a neurologist. Usually it's multidisciplinary in most institutions, either that or the physical therapist, but someone else is doing the ENOG.
Okay. And then when it comes to antivirals, I saw that for Ramsay Hunt, it seems like antivirals are recommended, but then it's kind of wish-washy for Bell's palsy. Is it known why antivirals work or are recommended for Ramsay Hunt but not for Bell's? Like why they're not as effective?
For Ramsay Hunt, it's a herpes reactivation, so it's trying to quell the herpes infection. Versus Bell's palsy, we don't really know what's going on. It might be related to an infection, and like the decompression thing, or I guess theory, there's just edema of that nerve that's maybe compressing in that labyrinthine segment. So whether it's a virus that's causing the edema or not, they don't really know. That's kind of why they do steroids.
Gotcha. Okay. Thank you.
Are there any other questions? Quiet bunch. Let's look at our poll. What did you guys decide? Can I share this? You want to do interviewing personal statements applications for residency. You're good with that? Adrian, do you want to talk anything about your experiences with the virtual interviewing?
Yeah, sure. So I submitted, I'm applying to fellowship. My interview season was supposed to be March through May. And then they were hoping that they would push it back and people would be able to travel between May and July, which has not really been the case. So all of my interviews have been through Zoom or FaceTime, actually, because I guess, I mean, I'm applying to a small niche, so people just kind of call and I kind of just FaceTime them. But at least I'm expecting it to be a little bit more organized. So at least for the organized interviews, I've done Zoom. There are little breakout rooms that you could do that I haven't really explored on this, but kind of 15, 20 minutes with each interviewer, and it kind of kicks you out. So it kind of, instead of someone knocking on your door and telling you like, you've got like 5 minutes or 2 minutes left, you just kind of leave mid-conversation, they get put into another room. And then the person that is interviewing is usually mid-conversation with someone anyway. So you just kind of jump in, and it's been interesting because then you just kind of talk about, I guess, kind of pick up where their conversation was or where it left off. There's a lot of COVID talk, which is not unusual, but it's been good in that I've been saving lots of money. It's bad in that, at least for you guys who are doing residency interviews, you can't really get a sense of the faculty or the residents, but you can only really base it off of like reputation, which, as going through residency now, isn't all that it really means. Like, I don't know. I've been happy with my experience, and I talked to other residents and they are not happy with their experience, even though they have other things going on that you'd think that people would be interested in. But I don't know if that helped or not, but